I am going to introduce our next speakers, Dr. Julia Frith and Dr. Laurel Robinson, two distinguished leaders in infection prevention and healthcare education. Dr. Frith serves as the manager of program development and research at Norton Healthcare and leads the Kentucky Infection Prevention Training Center. With over 15 years of direct infection prevention experience, Dr. Frith has been pivotal in implementing evidence-based practices to prevent infections across healthcare settings and has played a crucial role in developing plans for managing new and emerging pathogens, such as Ebola and COVID-19. Dr. Frith holds a Bachelor of Science in Nursing from the University of Louisville, a Master's in Nursing Administration from Bellarmine University, and a doctorate in nursing practice with an emphasis on executive leadership from the University of Kentucky. She's been certified in infection control since 2011 and is an active member of the Association for Professionals in Infection Control and Epidemiology, APIC. Currently, she serves as president-elect for the Kentuckiana APIC chapter. Dr. Frith has served on the National APIC Practice Guidelines Guidance Committee and is currently the Kentuckiana APIC liaison for Kentucky Society of Healthcare Engineers. Dr. Robinson is a nationally board-certified nurse practitioner and enhances the KYIP Training Center with over 12 years of experience in quality and infection control. Her background as a registered nurse, nurse practitioner, and infection prevention researcher brings invaluable insights to the field. Dr. Robinson has participated in numerous research projects, including collaborations with Pfizer and the CDC to promote vaccination in patients with cancer. With a passion for promoting diversity and research participation and advancing career developments for minorities, Dr. Robinson's expertise in infection control processes and cultural translation enriches the KYIP Training Center's initiatives. At this time, I'll stop sharing my screen and welcome Dr. Frith and Dr. Robinson as they tackle the topic of compliance in infection prevention.
All right, thank you very much. I am going to go first. So hopefully, can everyone see my screen?
We can see it.
All right, fantastic. Then let's go ahead and get started. So today I'm going to talk to you about the significance of collecting compliance data for infection prevention. And then Laurel is going to come on and talk to you all about how we get people to actually be compliant in the initiatives that we are working towards. So funding for this presentation was provided by the Kentucky Department for Public Health. Content includes discussion of unlabeled use of products. I have no financial interest or other relationship with manufacturers of products. No commercial support was provided for this educational activity. And then we partner with Project First Line and the Kentucky Department for Public Health. Project First Line is a national collaborative led by the CDC to provide infection control training and education to frontline healthcare workers and public health personnel. The Kentucky Infection Prevention Training Center is a proud partner with Project First Line to deliver the most up-to-date and best quality infection prevention and control training and information. So what are the objectives for our presentation today? So the objectives here are to define compliance and competence, indicate the importance of monitoring compliance, explain methods used to monitor for compliance, and describe methods for reporting compliance data. So what does CMS say, or the conditions of participation say, about the need for accurately obtaining information related to an individual's compliance with a particular metric? And so the CMS for Part 483 for long-term care facilities states, among other things, of course, it's a very long section, as I'm sure you all are all aware, that we have to have established and maintain an infection prevention and control program designed to provide a safe, sanitary, comfortable environment, help prevent the development and transmission of communicable diseases and infections. And within that, it acknowledges that there needs to be a system of surveillance. And this needs to be designed to identify possible communicable diseases or infections before they can spread to other persons within the facility. So this really highlights that idea of surveillance. I need to look and see what's going on so I can see if I have the opportunity or not to spread communicable diseases or illnesses or infections to other persons. The same holds true as it relates to the conditions of participation for our acute care facilities. So again, among other things within the conditions of participation, they're a bit more explicit and say they must demonstrate adherence to nationally recognized infection prevention and control guidelines, best practices for improving antibiotic use where applicable, and reducing the development and transmission of healthcare-associated infections and resistant organisms. So we know that we need to understand and monitor for compliance with particular metrics. And so really, what are those components of an infection prevention program? Components of an infection prevention program, base components include hand hygiene, standard precautions, transmission-based precautions, enhanced barrier precautions, prevention bundles, and immunization. So we know that these strategies work, right? Dr. Glowitz talked to us today about the importance of hand hygiene. We know hand hygiene prevents transmission of infections. Missy talked to us today about enhanced barrier precautions and standard precautions, and we know that that helps to prevent transmission of infections. But what we need to understand is what are the compliance, or what is the compliance with these processes? We know they work, but are we doing them? And that becomes the real question that we need to understand so that we can really work towards eliminating those healthcare associated infections that individuals have. And so this image here is a sample checklist that's been developed by the CDC. So it's a checklist for prevention of central line associated bloodstream infections. It goes through all kinds of great things, how the clinician can handle it, what they should be looking for, what the healthcare organizations should be looking for. And these tools are readily available on the CDC's website. And really, we need to take these tools and really understand what's going on within our facilities. So what is the difference between competence versus compliance, right? So competent, that is the state of being competent in something, right? I know what I need to do. I have sufficient knowledge to do what I need to do. Compliance, on the other hand, is the act or process of complying with that desire, right? I may know I need to do it, but I may not comply. I may know the speed limit on the highway, but I may still go over the speed limit. It's not a lack of knowledge necessarily, but a lack of compliance. And really what we need to understand is, why is there a lack of compliance in those situations where individuals have the knowledge? So that leads us into, why do we really want to monitor? Well, you want to monitor for something to ensure that the process and procedures are effective. So if you have a great program where you're monitoring for something and they're not, the outcome isn't changing, then there might be something wrong with your process. Without monitoring for compliance, how do you know where the problem is? So Dr. Glowitz mentioned 6 different opportunities, 5 different hand hygiene opportunities. If you look at the World Health Organization, 5 opportunities for hand hygiene. If we don't monitor, how do we know what opportunity is or what moment is our biggest opportunity? Nobody wants to be educated on things that are not a problem. And so you're not going to be able to know what the true problem is unless you monitor for compliance. And then how do you develop an infection prevention plan without monitoring for compliance and understanding what your continued performance improvement is going to be? And so Ruth is going to talk about having an effective infection prevention plan and doing that risk assessment. But to really drive your plan, you need to know where your areas of opportunity are. And if you were not watching or monitoring for that and seeing where our compliance is within our bundles or within our metrics, then really we don't have a good way to drive our infection prevention plan and really stop those healthcare associated infections. So what we need to consider, though, is that before you monitor, you need to develop a definition of what you're monitoring for. And so what's that mean? Well, that means that if I'm monitoring for hand hygiene and I'm thinking that we're supposed to look at monitoring for in and out of the room, and my colleague thinks that we're monitoring for hand hygiene of just contact with a patient, we're not looking at the same things. Not suggesting that it's not both valuable bits of information, but they're not the same. They cannot be compared as the same activity. So you're going to want to develop that standardized tool, that tool that says, this is what the definition is, this is what we're looking at, this is how we are going to do the monitoring for this particular action. I mean, you're going to want to understand the Hawthorne effect or that bias. Right? So that idea of going and monitoring the same person all day long may not be the best choice. At some point, their behavior may change. Do you want to monitor during a time that a patient's become very acutely ill all of a sudden or in the middle of a code? Maybe that's not the best time to monitor for compliance. And then documenting what is seen. It does not help if you monitor for compliance, but you document as compliant after you told someone to do something, right? So if you're monitoring, for example, dressing changes on a central line, and you come to me and say, Julia, your dressing needs to be changed. It's non-occlusive, and I change it. If I document it as an occlusive dressing, then we aren't going to understand that loose dressings are our problem, right? And so understanding that monitoring for compliance with our processes is not a punitive thing. It's really to understand what is our next step. What do we need to do? And so the CDC, I have the link here on my slide deck, has some very beautiful quality checklist that they have developed for everything from central venous catheters to point of care testing, vaccine storage, cough courtesy within waiting rooms, some really beautiful documents. So they've got the standardized tool, they've got the definition of what's being monitored, and it's a simple yes, no. Did they do it or did they not? Or was it when you walked into that space, was that item where it was supposed to be or was it not? Was the alcohol gel full or was it empty? And so working towards understanding before you monitor those tools really helps you to be able to have information or data that's going to be of value to you. So how do you do the monitoring? So, again, conversation earlier as it relates to our hand hygiene presentation, we really need to understand what method of observations do you plan to do? So are you wanting to do observations related that are direct, overt observations? Maybe so. Maybe by doing this, you're going to be able to understand and get that immediate feedback, right? No, Julia, stop. We need to do something. We need to change something within this action before you go forward. I can ask straight off, Julia, what were the barriers that were present that prevented you from being able to do whatever it was that we needed that person to do, to be able to follow this bundle? What were the barriers to you to being able to perform hand hygiene? Obviously, the weakness to that is you're going to have potential bias, right? I know you're watching me. I'm going to behave differently. Probably not because I want to, but because I just will, right? But it also will show you if I don't do it, I legitimately have no clue that I should have. Covert observations are very important as well, because these really help you to understand what barriers can be identified. And so if I'm watching you I'm going to be able to see the barriers to you being able to do what you need to do. Whatever it is that you choose to do as it relates to your program, I would suggest that you do any combination of the such. Have some of your observations be covert. Have some of them be overt. Have some of them be patients as an observer or coworkers as an observer, right? Then you'll be able to see multiple different ways of seeing where those opportunities absolutely could have arose. So you really want to have a control plan or a measure of definitions. So if I'm going to perform hand hygiene observations, who am I performing it on? And what am I looking for? So maybe I'm performing hand hygiene before contact with a patient or a resident. The definition of that is performs hand hygiene prior to touching the patient or the patient zone. Well, it's very important that I know what the patient zone is, because if I don't, then I may not give you the same amount of information as my colleague, because we may think or determine that the patient zone is different things. So making sure that within your definitions, you say these things are part of the patient zone. The bed, the bedside table, the call light, the medical equipment, so that I know when I'm doing observations, if they touch those things, they need to clean their hands, right? That allows for the observations to be done in such a capacity that we can utilize this information and really make a change. So it's not just enough to say, yes, I monitor, I look at people, I watch them. We really need to develop that data and put it into such a capacity that it tells a story, right? Sometimes compliant or sometimes non-compliance, or I think that they do a good job, isn't enough to be able to change practice, because the question's going to become, what is the problem? What is the opportunity? What is it that is inhibiting them from doing the right thing? Because it is highly improbable that it is a direct choice that they just don't want to do it, right? So how you display your information or calculate your information is really a decision that you have to make within your facility. But this is an example of bundle compliance with a composite score. And the idea of a composite score is that it is all or nothing. There are 6 elements to the central line bundle. You have to do all 6 elements to be considered compliant. If you do not do all 6 elements, then you are considered non-compliant. This tells you the story of what is my compliance with the bundle itself, right? And so one of the ways I look at this when people get really upset, right? Because arguably, excuse me, we have relatively high compliance amongst at least 2 of them, right? They're at 100%. One of them is in the 90s and the other one is right at 90%, right? Well, the question becomes, if you go to a patient and say, I have a bundle, it's 6 elements, I'm only going to do 5 of them. Which element do you not want me to do? Which of these elements is not important, right? One isn't more important than the other. So if you look at things from a bundle perspective, then you need to look at what is the compliance with the entire bundle. And so in this scenario, you can see that bundle compliance was a little less than 60%. But it also tells a beautiful story. If I'm the infection preventionist and this is my data, I'm probably not going to develop educational or work with staff to understand or go out and talk to my colleagues about lines being dated and changed or hub disinfection, right? Because we're doing really well at that. But I am going to go out and understand what is the opportunity, what is the challenge that people are seeing that is inhibiting them from being compliant with their dressings being dry, inclusive, dated, and timed, right? Then I can focus my education, my infection prevention plan, and hopefully achieve the outcome of no bacteremias because I'm focusing on the area that is my biggest problem, which in this fake scenario of data from 2036 is my dressing, right? And I'm not spinning my wheels working on a problem that doesn't exist, hub disinfection prior to accessing the device. If you do a weighted average, which is adding all the total correct opportunities and dividing it by the total, in this scenario, the weighted average would probably be about 90%, right? So you may not look like you have an area of opportunity because weighted average, all my compliant versus all my available opportunities, tells me a very different story. It tells me I'm doing relatively well, but I'm just not doing good with the bundle, right? And so if you never have compliance with continued need, but you are compliant with everything else, you would have a composite score of 0, but your weighted average would be in the 90s. So understanding the difference between total compliance and total bundle compliance is very important. Not suggesting that both of those bits of information aren't important data points to share, but really you have to think through, what is it that I want to do with this information, and how is it going to guide me to the next step within my process? This is a beautiful document that, or monitoring tool that is on the CDC's website. And I know that it is a bit small, but I wanted to highlight this because it is very nice in the fact that it is a workbook, an Excel file already established for this on the CDC site for environmental monitoring. And so it's got high touch area 1, 2, 3. It's got different elements within those high touch areas. And when you answer the questions according to what they've got here, so 0 for not clean, X for clean, or leaving it blank, it adds up your score. It provides you with a compliance score. And then it also provides you with categorical scores for each of those things. So again, I might have a compliance score of 85%, but it's going to tell me that my biggest opportunity is within the high touch 3 area. And so that's really where I need to focus my attention, because let's be honest, we don't have time to focus our attention on everything all the time. And so when we monitor for things, we can understand, what is it that I need to focus on now? What is it that my plan needs to be a part of today to make a change so that I can improve whatever my outcome is? So how do you display the data? You really want the data to tell you a story, right? What is happening? If I'm going to present this to somebody, I want them to be able to look at the table, the graph, the picture, and say, wow, I see what's happening here. I don't have to figure this out. I see it straight off. And so in this scenario, I've got an infection being monitored. It's a fake value, but this may be the rate of transmission for your C. diff infection. It might be the SIR for your CLABSIs, for example. It really just depends on what you want that to be. And in this scenario, I've got a secondary axis. So I've got a secondary Y. One of my y-axes is showing the rate of infection being monitored. One of my y-axes is showing the % of hand hygiene compliance. And then across my x-axis, I have the month. So a couple of things to point out here is, look where the axes values start. So for hand hygiene, for example, in this scenario, the axes value starts at 40%. Because we're not at, when are we going to be at 0% hand hygiene? So it's, if you have all that dead space, it just really makes the graph very difficult to look at. And there's really no point in showing that. And so in this scenario, you can see as my hand hygiene compliance improved, my infections that were being monitored decreased. I had a high rate of infections when I had a low hand hygiene compliance. I have a high hand hygiene compliance, and I have now got a lower rate of infection. Right? And so that's what you want to see when you're looking at these tables. It is very easy to say, There's an intersection there. It is very easy to see that I have an upward trend with my hand hygiene compliance, and I have a decreasing trend with my infection being monitored. You can use this type of graph to show impact of improvement over time. So for example, as compliance with hand hygiene increased, the rate decreased. Be sure to have it as a rate. So, you probably don't want to have number of infections, right? Because that could get relatively confusing. But if you do it as a rate, patient days, device days, attack rate, whatever that is, you'll be able to show a beautiful picture. So the next question becomes around looking at data over time. So how many have seen a hand hygiene compliance graph that looks like this, right? This is compliance for my facility. This is fake compliance. This is not real data, but this is compliance for the facility that is over the last 7 years. A couple of things to consider. It is not relevant what we did 7 years ago, right? 7 years is a very long period of time. And so this graph shows beautiful upward trend. I started out really low, I went really high. This is nice if you want to look at the big picture. What have we done year over year over year? But typically you want 36 data points. So you could do a rolling 3 years if you're doing it monthly. You could do it 36 points of whatever it is that you're looking at, weeks, months, quarters, whatever that is. And so if we look here at this same data with less date frames, right? So this data now is over 2 years instead of 7. You can see that, in fact, over the last 2 years, our hand hygiene compliance has not improved. And actually, it's decreasing, right? But like I said before, check out the axes, my y-axis here. I have it starting at 0. So we've got all this white space. And this white space really isn't relevant. And it's not helping to really show a good picture. And so if you show it with an adjusted axis, right, of 75% and up, you can see that, in fact, it is a much more obvious decrease in your compliance, right? And so I'm not suggesting that you do this with every bit of information that you're sharing, but in some scenarios, for example, hand hygiene, 10% difference is meaningful information. But it won't show as obviously if you don't see a decrease over time. So by restricting that y-axis, you can see what is happening. So 10% difference may not be as big of a deal in some other scenarios, but 10% difference with hand hygiene going over 10% decrease over time, that's a problem, because when are you going to recognize it? You don't want to start to recognize that you've got a problem when your hand hygiene compliance is at 50%. It is much easier to recognize that you've got some opportunity for improvement when your hand hygiene compliance has gone from 95% to 85%. It's not as easy to see that. So if we go back to the other slide, it's not as easy to see that when you present it in such a way like this, right? And so really understanding how you set that picture will help to drive what it is that you have to do or what areas of opportunity that you need improvement in. And so, like I said, the issue 99.9% of the time is not that individuals don't want to do the right thing. We all want to do the right thing. People get into healthcare because they want to do the right thing. The issue is that there's likely a barrier or something that is inhibiting me from being compliant with these metrics. And so the next session that Laurel is going to talk about is, we've got this information, right? I've got this data. My hand hygiene compliance is decreasing exponentially over time. I need to understand why. I need to be able to do something with the data. It does not help me to say, I've got all these beautiful charts, look at them. and then have nothing done with them. And so at this point, I'm going to hand it over to Laurel so that she can present on helping understanding of the barriers. Laurel, I'm going to stop my screen now.
Thank you, Julia. Can everyone hear me okay?
You are a little soft.
Okay, scoot up a little bit here. All right, I'm going to try to share my screen here and make sure everyone can see it. Okay, can everybody see my screen okay?
We see you. Thank you.
Wonderful, thank you. Okay. All right, so thank you for the introduction, Julia. I'm Laurel Robinson, nurse practitioner here with KYIP Training Center, and I'm going to be presenting a presentation on exploring the barrier identification and mitigation tool when we are dealing with compliance. Okay, so I do not have any financial disclosures. Julia did cover that earlier, I believe, in our presentation. So we'll just hop right into the objectives. Before I start, I do want to let you know that I did place a link on the chat while Julia was speaking. I just wanted to make sure you all received it. And it looks like Kirsten's actually attached a live link to the website. And this will be for the BIM tool, which I'll explain during the presentation. You don't have to look at it now, but this will be something you may want to refer to later if you want to implement this tool in your facility. Okay, so our objectives today are going to be to identify 2 causes of harm to patients that relate to compliance or guidelines. We are also going to list 3 common barriers to compliance. There'll actually be more than 3, and we will define the BIM tool. So despite the major efforts to improve patient safety by developing compliance policies, a significant number of patients still continue to suffer harm that is preventable. Much of this harm results from a failure to standardize care processes to ensure that patients receive evidence-based interventions. Guidelines and policies summarize evidence to help ensure patients receive recommended interventions. However, compliance with evidence-based guidelines can vary anywhere from 20% to 100% if it's our dream situation. And of course, Julia kind of touched on that. You know, we know there's a problem, but we have to figure out why people are not following the compliance guidelines. So sometimes, you know, we could go straight to assuming, is this education, a lack of education, our understanding perhaps of the guidelines themselves? You know, while lack of education may contribute to a lack of utilizing compliance and evidence-based practices, in some cases, that's really not the sole determinant. The truth is there are many factors that can impact whether compliance to evidence-based guidelines are followed. Being able to identify these factors will prove beneficial. So some barriers to compliance that I will discuss are going to include these following bullet points here, but basically, to sum it up, poor communication between leaders or coworkers can result in confusion about guidelines. It could appear that the employee was not being compliant when they were truly just unaware of the guidelines. So it's important to know that, you know, these guidelines are out and that the staff is aware of them, first of all. There may be unconscious or even conscious bias that prevents employees from adhering to a guideline. This could be a lack of education on the topic at hand, or personal experience that has left them with a specific impression of why or why not the compliance step is of importance. If an employee has a high workload or working short-staffed, they are less likely to adhere to compliance regulations, unfortunately. That's just what we see in real life. A lack of supplies that are needed for a compliance intervention. If there's a lack of supplies, then we could end up with a lack of compliance. And also, again, time management pressures can result in poor compliance as well. So various toolkits have been developed for the purpose of identifying and removing barriers to compliance. in all types of settings. One such tool that we will discuss today briefly is called the Barrier Identification and Mitigation Tool. This was a tool that was developed by experts at Johns Hopkins University, and it offers a practical interdisciplinary approach to identifying barriers to guideline compliance and to implementing action to eliminate or mitigate the effect of the barriers. Again, the BIM tool is just one of many tools. This is a one that really does focus a lot on aiding in quality and safety improvement efforts and to translate evidence into practice. And what I like about it is it gets everybody involved from the top down. Julia, are you hearing me okay? Yeah.
We can hear you.
Thank you. Okay. So ICU Keystone Project in CLABSI. This was an interesting study that I came across on an earlier version of the BIM tool was used in this particular cohort study. It was back, I believe, in 2006, if I'm not mistaken. It was basically a study that was conducted in 103 Michigan ICUs, and it actually resulted in a significant reduction of CLABSIs. The tool was instrumental in identifying a variety of provider, guideline, and system barriers to compliance with the evidence-based guidelines and in implementing action plans to eliminate these barriers. For example, using the BIM tool, the team discovered that many of the ICUs that they looked at lacked chlorhexidine in their central line bundle kits, making compliance with using chlorhexidine difficult because the person would have to step away, possibly from the sterile field, not realizing that it wasn't in the packet. So as a result, they had, low compliance with this particular surgical or skin prep. ICUs had not ordered central line kits that contained all that equipment and the supplies needed to comply with this checklist. So it was something as simple as revising the order, and making sure that they did have the correct kit ordered for future. Now, of course, this BIM tool has been revised since this particular study, and it was based on suggestions of participants in that study to be more explicit and include a rating of barriers and interventions. So if you go back and look at this one again, it's a little earlier version of this toolkit, but it's still interesting, and it kind of propelled the movement to go forward with perfecting this tool. There's a little screenshot of the article from the New England Journal of Medicine you can refer to later if you like. It's in the references. So guidelines, our problem statement, guidelines summarizing evidence exist, as we have heard earlier from my colleague, Dr. Frith. They exist to help ensure that patients receive recommended interventions. In addition, consistent guideline adherence may significantly improve patient safety. However, adherence to the evidence-based guidelines remains highly variable. So we are going to look at this tool and see if this will help us to record these interventions. We have discussed some barriers to achieving consistent adherence to evidence-based guidelines. Another important point to make is that barriers can vary based on the areas of care they apply to. So that's what's really good about this tool. It takes information from people in the unit of all different disciplines and utilizes that to find out what the true problem is for that particular unit in terms of barriers to following compliance. And that, again, is because different barriers can and solutions can vary depending on where you are. Are you in a huge multi-million-dollar facility, hospital that has everything at hand? Or are you in a smaller facility, maybe in a rural area that does not have everything possible to, comply with whatever the rule is? This tool will help provide This tool will also provide a framework for developing an action plan targeted at eliminating or mitigating the effects of the identified barriers. So we're going to provide a practical and interdisciplinary approach to these barriers. Okay, next slide here. All right, the tool is very versatile. It's another reason I like it. you really get everybody involved in this. It's from the frontline clinicians, such as your physicians, your nurses, nurse management, nurse practitioners, PAs, all the way to non-clinical staff, from, executive levels, such as your hospital quality officers, hospital safety officers, directors, and such, risk management, et cetera. And even to ancillary staff is very important. Some of the best suggestions come from ancillary staff on problems with compliance, because they are really in there doing the work day in, day out. So the BIM tool is best applied with the context of a comprehensive quality and safety improvement effort. This is by far not a one and done tool to solve all your compliance issues in the world. It's just one part of the process. The tool also should be used periodically, maybe every 3 to 6 months is what's recommended. And that's to help identify any new barriers or any changes in barriers that have happened. And also to, as Julia mentioned earlier, to actually see where you stand. You have to monitor compliance in order to get an idea of whether the adherence is poor. And then you want to work on finding out why. Okay, so again, I mentioned the links are in the chat if you'd like to follow along with the AHRQ safety program for surgery toolkit, or you can refer to that later. I am going to explore the toolkit on the next several slides briefly. Okay, so I talked about getting an interdisciplinary team together. We want that to be a diverse team, again, including clinical and non-clinical members. We want to encourage people to participate. Some of the best suggestions, again, are made by people you would at least expect. And you want your participants to be familiar with the overall strategic plan for your unit or for your department, for your facility, in terms of improving quality in order to participate in this. They need to at least have a baseline idea. So that was step one. During step two, several of the team members are going to work independently, and we'll go into more detail in just a moment, but basically these team members are going to split up and focus on identifying these barriers. We talked about overt and covert monitoring. This is going to be covert, private eye, special secret monitoring. You don't want them to know with this particular tool that you are monitoring them. And it's easy to go down a rabbit hole when you're trying to identify barriers. So this tool is really good about helping you to categorize these things. So several team members should walk through the observation process. Do this by observing a few clinicians and staff members engaged in the tasks that are related to the guideline. They should not be aware that they're being observed. As an observer causes little distraction as possible, the setting that the observation occurs in should be natural and indicative of a typical day-to-day environment. So for example, you want to avoid observation in an area under construction, or maybe you have a lot of staff that is not normally in that department. Try to make it as, as realistic day-to-day activities as possible when you're determining barriers. Focus on observing rather than documenting during this period. Jotting a few notes is okay, but you don't want to cause distraction. That's going to maybe give people a heads up that they're being watched, and then you're going to get tainted data at that point, which is just, human nature. So it's important to try to do that. And along with the barriers to achieving consistent adherence to the guideline, you want to indicate any skip steps or workarounds that you're noticing. Such as improvised process steps are factors that facilitated the lack of compliance with the guideline. Speaking with the people who are actually performing the task is invaluable. I can't say that enough. Method 2 is where you seek feedback from staff. So you've done your observation part. Now we're wanting to compile this information and look at it, and also just to hear the perception from the staff that was monitoring or observing rather, what they feel like is the issue. You want to include these as informal discussions, interviews, maybe focus groups, brief surveys, Make sure these occur in a safe environment where staff feels that they can share without fear of retribution or ridicule. Again, as Julia mentioned earlier, not punitive. We want to make sure that we're, getting honest data and that people are forthcoming with that and without fear. We want to ask the staff about problems they face and any ideas that they have regarding potential solutions for improving compliance to guidelines. Some of these questions would be, are the staff aware that the guidelines exist? Do they believe the guideline is appropriate for their department, or their facility, or their patient population even? Do staff have any suggestions to improve compliance? And then the walkthrough method, I'm just going to touch on this briefly. It can take hours. The way it's described is that you are really actually going to walk through this process of the guideline, meaning comply with the guideline. And you can use simulation, which is great. Or you can, use this if appropriate under real circumstances. But you want to continue collecting data until there are no new barriers identified. So this is why this is such a time-consuming part of this particular process, but very valuable. So the investigators are recording all potential reasons that clinicians experienced difficulties with complying with the guideline in the barrier identification table. They will also record the factors that encourage compliance. These are the facilitators. Indicate the method of data collection, whether it be observation, survey, focus groups, informal discussions, interviews, or walking the process. And then the data collector and the clinical unit. So all that will be filled out in this particular part of the tool. The focus of this part is to determine whether the staff have the knowledge of the guideline and know the elements. You will gather information about their attitude about the guideline, what they currently do in practice, and also gain insight into their own perceived compliance of the guidelines, like how often they think they do everything right. They may really honestly think that they're following the guideline, and truly they're not. So that's an important step to mention. In this portion of the barrier identification table, the focus is on the guideline itself. Evidence supporting this guideline, whether it's applicable to the units, patients, and how easy it is to comply with the guideline without getting behind or adding too much to the existing workload. The system portion of the barrier identification tool focuses on the system factors such as the physical environment, whether ample supplies and equipment are available, supportive leadership, the unit culture. You can look through this again through the links that we provided in more detail. Okay, now we have our raw data. We can take the time to compile that information from the various investigators identified from the barrier identification table that we just discussed. So this information is then going to be placed systematically into the barrier summary and prioritization table as pictured on this slide. These categories include barriers, relation to the guideline, source, and then there's going to be some scores that we'll talk about here, the next slide. So using the barrier identification table, we summarize the information and insert into columns 1, 2, and 3 of the barrier summary and prioritization table. Column 1 is just going to briefly summarize each barrier. Column 2 briefly describes the part of the guideline to which the barrier applies. And then column 3 is where you provide your source of the data collection, how you came about that information, whether it was the observation, survey, interview, etc. Okay, so then the interdisciplinary team should then review and discuss the barrier summary. In columns 4 and 5 of the barrier summary and prioritization table, they will rate each barrier of the likelihood that it will occur in the unit and the severity of the barrier. And if you can see here, the rankings are low, moderate, high, and very high. So again, some barriers are going to be easier to conquer than others. Some are more important than others. So this is where you kind of get down to, ranking everything in the order of importance so that you can mitigate that in a priority type method. Okay, column 6 of that table is to multiply the likelihood score by the severity score. And that's going to give you what's called the barrier priority score. As a team, you're going to list and review potential actions to eliminate, mitigate the selected high priority barriers in the action plan development table as suggested by the observers. This is a screenshot of the action plan development table. We will discuss that briefly in the next few slides. So using that action plan development table as a team, again, we're listing, reviewing potential actions to eliminate and mitigate selected high priority barriers. You want to start with those high priority barriers. Brainstorm for any additional potential actions and add to the table, and then select specific actions to address in the next improvement cycle based on the potential impact to compliance and prioritization. Rate each action with potential impact score and a feasibility score. This is another math problem here. The action priority score is calculated by multiplying the potential impact score by the feasibility score. Your team can prioritize the actions and schedule as appropriate for your clinical setting at that point. And it's a good idea to select specific actions as a team to address in the next improvement cycle based on the potential impact and compliance and the feasibility with the current resources as well. So I have an example here with that. So for instance, you know, it would not be really nice to have a new sink in certain areas of your facility. But we know realistically that's thousands of dollars. Your facility may not have that in the budget. So the next thing would be something more cost effective, such as utilizing or installing hand hygiene, like hand sanitizer stations, for instance, at areas that are high traffic. And again, that would save a lot of money and you would still be able to help with the compliance issue. So in summary, the BMI tool, again, is just one of many tools. You can look around yourself. This is just one that I tend to like. I have a surgery background, so we utilize this a lot in the surgery setting. But by systematically identifying and mitigating barriers to guideline compliance, the BIM tool may increase the reliable delivery of evidence-based therapies to patients and a more reliable delivery of recommended care, which can improve the quality of healthcare and patient outcomes. So again, compliance, so important. So just to review here, we identified 2 causes of harm to patients that relate to compliance, and that would be failure to comply to standardized processes and failure to ensure patients receive evidence-based interventions. 3 common barriers, I listed several, but they include an ineffective communication, unfamiliarity with the guideline, disagreement with the guideline, high workload, etc. And define the BIM tool. Again, that's the barrier identification and mitigation tool developed by Johns Hopkins. And it is designed to identify barriers and develop an action plan to mitigate and eliminate them. Again, just one tool in your arsenal. It's not a standalone thing, but it will help to focus in on what the true problems are and the high priority problems of your compliance issues. And with that, I'll end with my reference page. And I don't know if we have time. I think I obviously went over. So if there's any questions, let me know, or we can answer those again on the website at a later date. We're compiling those for everyone.